Huge welcome to everybody. Lovely to see all of you. I hope you're all keeping well. It's really important, I think, before we start, just to say, from our perspective, you need to keep yourselves safe. So whatever the rule change next week, do be careful. And obviously it's entirely your choice what you do when you're outside the hospital, but I care about your well-being. And there does seem to be a lot of evidence that being careful is a good thing to do. So, just do look after yourselves. Right, so we do have some apologies for absence this morning. Anna Hills is on holiday, taking a well-deserved break, but we have John Barber, who is acting as the Deputy Chief Executive, and you already know anyway as the Director of Strategic Projects. So it's lovely to see you, John. Welcome. And we also have apologies from Jose Bemonde, who's one of our public governors. We haven't had apologies, I think, formally from anyone else, but Anne, let me know if I've got that wrong.
Yeah, have we had Dev's apologies, Bridget? I think he wasn't able to make it.
Yes, sorry, I put it in the chat for you, Anna. Sorry. So
sorry,
no, that's absolutely fine. So we've got Dev Khurana, Stuart Brooks we mentioned, and Jan McCarrick is going to be late.
Oh yes, Jan did let me know, so thank you for reminding me. That's perfect, thank you. And thank you, Bridget, for minuting for us today. It's lovely to have you there too. So any declarations of interest that we're not already aware of? Raise your hand if there's anybody wants to speak. If not, can we move to the minutes of the meeting held on the 5th of May, and we'll go through them for accuracy. So page 1, 2, 3, 4 and 5. If there are no comments, then is everyone happy to approve those as an accurate record? Thank you. If we can move to the actions, which are green, Anne, would you confirm that those have happened?
Yeah, that has been completed, but I did want to provide an apology that there is an outstanding action around the virtual membership event that we had planned to take. Unfortunately, other priorities like the governor's elections have just taken over, but I would like to get that scheduled before this council finishes. So I think I'm going to try and do some work on that next week.
Thank you, Anne. So we have, are you going to amend the action log to reflect that?
No, it wasn't an formal action, but I just want to let the council know that I'm aware that we haven't progressed it yet.
Okay. So we have no outstanding actions other than that one, which you've obviously verbally informed us of. So there's nothing to confirm there. So we now have a clear action log. So if we could first of all then go to the next item on the agenda, which is the patient experience performance element, and we're going to start with John, who will be, as I say, representing Anna today to give a little bit of a perspective from the Chief Executive's perspective to all of the governors. So John, over to you.
Thank you, Chair. Good morning, governors. Good morning, colleagues. Yes. You can see the main points on the slide. I'm going to sort of mix it up a little bit to start with the challenge, but then move on to something which I think you'll agree is significantly more positive. The challenge is, sorry, the slides are there, good. The challenge is very much about operational pressure. We seem to be recording on a fairly regular basis the busiest day ever in ED. And only last Monday we had another one of those busiest day ever, and that was 335 attendances at our emergency department. I think this is really quite reflective of across the whole system. So primary care are truly under pressure, as well as our community colleagues. And our team is working flat out. And I think, to be honest with you, this is as it is now. And I think the summer is probably going to be extremely difficult for us, irrespective of additional waves of COVID. And interesting, the East of England Ambulance Service are predicting that the summer will see another 6.4% increase in the amount of activity they're bringing to this hospital. And we are particularly challenged here as well. Interestingly, I think it's Tourist England have said that Galston this year is the 5th most popular seaside destination. So that is going to see an influx of people, as well as the staycation. People will be obviously staying at home as well. So I think we are in for an incredibly challenging time. But we have to commend the teams at the hospital, ED, the flow teams, and everybody working on the wards for actually managing to tackle this extreme pressure, and doing so with the energy which is surprising as we've just come out of COVID. So it is a really challenging time, but we are doing everything we can, and we are having a lot of work with our partners. This is really moving to the system working point at the top there. We're having regular MAID events, which are multi-agency discharge events, and they are being really effective. So we're working with all our partners to get people out of the hospital as soon as we possibly can. And the 3 trusts are also working incredibly closely together. I've only just come off a call with the other chief execs to see how we can jointly tackle some of these challenges we're having. So moving on to the more of the positive side of where we're heading at the moment, the elective recovery work is continuing, and we are eating away at our elective waiting list, which is a really positive thing for those patients that have been sitting waiting for their elective surgery for months now due to COVID. So we're making good inroads into that. And we're also really, really pleased that as a system, we're making really good inroads into that. And Joe Segersby, our coup, is working very closely with the chief executive of the Queen Elizabeth, Caroline Shaw, leading the elective recovery programme for the whole of the system. So there's an awful lot of really positive work going on. After a break, we will be seeing the Paget's People Awards being launched in a moment or two. I'm going to talk about Operation Reset, but I think this is really important to try and show and demonstrate really clearly how valued our staff are. So we are hopefully be having the Paget's People Awards again this year. We've got 2 governors on the organising committee, and this is really important. This is something which does undoubtedly unite the organisation. We are also now an accredited veteran aware organisation, so it does show our support to the armed forces community we also do serve. Just moving on very quickly to that last point, and it's a really important point, and it really backs up what the chair just said at the start, is about looking after oneself. Despite the easing of restrictions for next Monday, we will be as you are in the hospital, so masks, social distancing and one-way systems. This is exactly the same approach, and as I've just been discussing this with the other chief execs in the system, the same approach that's going to be taken by all healthcare organisations in our integrated care system. So we are being very mindful of the people we are working for and with to make sure that they are protected. So it is as is from Monday, not taking masks off as the general population will be able to, but hopefully won't, one would say. So if we can move on to the next slide, please. Now, this is really important. So we've really understood during COVID how we've worked better as an organisation. We've been much more speedy in our decision making. We've deployed people to work from home at short notice, and my goodness, it's worked really well. So we've learnt an awful lot. The fact that we're doing this over Teams is a real clear indicator of how much we've changed in the way we work over the last 18 months, 2 years, really. And Operation Reset has been very much about how we can engage the whole organisation into setting what the future working arrangements of the hospital will be. And this is important, not just as a response to COVID and any future waves of COVID, but also in response to the space requirements we need as a hospital. We don't actually have enough desks for many of our staff now. And I appreciate we're going to be having a new hospital in a few years' time. We need to do something in the meantime. So blending all that together we've formed a new programme board, which is chaired by the Chief Exec, and that's Operation Reset. And there's a number of work streams underneath that. Working inclusively, your leadership, working differently, smart systems, and listening into action. I actually co-chair with a member of staff the Working Differently work stream, and we're looking at many different ways that people can work differently. So we're calling it hybrid working. So people are able to work from home, flexing their working hours to meet their own well-being issues and fit in with their work-life balance. But there is two sides to this. In doing that, we are looking at expanding particularly the hours of operation of back office functions, so that if you are a nurse who obviously can't work from home, when you finish your shift at 8 o'clock in the evening, we are hoping that there will be someone available to speak to you should you wish about payroll issues, HR issues, etc. So there is a real double-sided benefit to this working differently, this hybrid working. And Smart Systems is also looking at how we can deploy new technologies. We're using Teams right now, and many of us don't even scratch the surface of the functionality of Teams. You can do live, real-time polls and surveys whilst you're giving a presentation, and this is going to be the way we're going to be delivering our business in the future. So Operation Reset is really being driven by people from across the organisation at every level. Although I'm the exec sponsor, I don't chair that group. That's chaired by another member of staff. We're driving it down so people have control to direct and tell us what they want to do and how things should be differently in the future. So I think this is a really important Operation Reset, as we're calling it. It certainly really will shape the way we work as an organisation going forward. And it's also making sure that we embrace all our diverse communities, not just those that work here, but those we provide services for. So that's my sort of brief update. I don't know whether, Chair, any questions now, or you're going to move on to do questions later on, but thanks for listening. You're on mute, Chair.
There we go. Thanks. We would traditionally have questions immediately so that they're fresh in governors' minds as we go through each of the slides. But thank you for providing a real flavour of the key things that the hospital is dealing with at the moment, and obviously the key things that the board is concentrating on, because, you know, actually what you've reflected are the key issues that we're working through at the moment as a board. So I can see Lynn. Is that you, Lynn, or is that Jim?
Can you speak now?
One question. The wearing of mask is not mandatory after the 19th. What happens if a visitor refuses to wear a mask? Are you going to refuse their admission into the hospital?
John, would you like to respond?
Yes, we will be having people at the front of the hospital giving advice and support to the people coming in, but our rule will be you do need to wear a mask. Now, there are obviously going to be variations in that. Some people don't wear masks and they don't necessarily wear the sunflower lanyard. So we are going to obviously be very delicate how we do this, but there is our rule on our site will be you wear a mask.
Thank you.
Thank you. Ian, would you like to come in?
Yeah, morning, John. Can I just ask for a couple of little bits more detail on the early bits you were talking about, the operational pressures? Can you give an indication of where those pressures are coming from? I know, for example, there was lots of concern over young children, the under fives coming. Where's the pressures on ED? And secondly, you were talking about the elective recovery. You said you're eating into it. That's a little bit vague. Can you give just a little bit more on the progress of what eating into it actually means?
Ian, what I will say is I think John will be able to give you some of that detail now, but obviously those are the things which when you look at the board reports, all of that detail comes into there. So what we try to do is reflect a strategic overview rather than present all those details, because otherwise we're just repeating the board meeting twice, which obviously is something that, you know, we're not, that isn't what the council is there to do. But I'm sure John would happily give you a flavour of where that pressure is occurring.
Yeah, and that's a really astute point and a question you raised. The first one is, where is the pressure coming from? And interestingly, it's across the board. It is both paediatric and adult non-elective attendances, which are giving us an extreme amount of pressure. Just to give you an example, in June 19, pre-pandemic, compared to this June, we've had an 11% increase in ED attendances. So that is the scale of it, pre and now, and it is across the board, paediatric and adult. And these are people which are really quite ill as well. So there could be a blend of things happening here. It could be those people that have not seen or had access to a GP during the pandemic, and therefore their conditions have got worse. And obviously it's the issues such as long COVID and other COVID related issues. So it is across the board. In answer to your second question, I do know that the latest numbers were being crunched yesterday, so I'd rather defer to the board report, but we are making positive inroads into that elective recovery programme. But I'd rather not give data right now, because that was probably out of date as from yesterday, but we can follow up on that at another point. But thanks for the question.
I think I would just add, Ian, to that answer, that it's always difficult to exactly know, if you like, what reasons somebody has come to ED, because clearly how you collect that data and then how you reflect it, it isn't an exact science. And of course, they're dealing with those emergencies. They're trying to get through them as quickly as possible. They don't always, if you like, ask there isn't a form that you fill in to say why you're here. So all I would say is it is reflected not only across Norfolk and Waveney, that increase, but it is across the country. And there does seem to be a kind of an issue relating to the fact that people were not presenting during the early stages of COVID for all sorts of different reasons. And those people, as John has said, are potentially now emerging and obviously more ill than they were previously. But equally, it depends on where we are. And of course, in our part of Norfolk, we don't have easy access to an urgent care centre, which I know exists, for example, in Norwich. So I know some work is going on across the system to see whether we can introduce something more locally that could perhaps siphon off at least a few of the people who otherwise would turn up at the front door. And as John says, we're very conscious that we haven't reached the summer holiday yet. We always get a surge of patients in the summer holiday, and at this stage, we're seeing well above the numbers that we had even in the year prior to COVID. So there's definitely something happening which needs really careful responses. But what you can't do is shut the front door. You can't simply say we can't take any more. You have to cope. So it does mean longer waits for people, and that obviously we are trying to work through, and we try to minimise. Does that help? Thank you. Now I've got Mary and then James.
Yes, thank you. I'm not sure if some of the problem is it's very difficult to get a doctor's appointment at the moment, and I think that is putting pressure on the ED.
Thank you, Mary. That's something I have heard referred to at our partnership board meetings, which involve everyone from across Norfolk. And I've heard the response too that's been given from our CCG colleagues, from Melanie Craig, who, as you know, is the accountable officer for all of the CCGs. Her opinion on this is that, yes, there are some surgeries where that might have been and continued to be a problem, but that it is a minority. But she was very clear that if individuals have experienced that issue, they should be raising that directly with the surgery itself, but equally with the CCG, because it's only if they know about that experience that they can tackle it. And the problem with a kind of anecdotal, all GPs are doing this, we know that that's not the case, but equally it doesn't help in terms of being able to tackle, if you like, the worst offenders. So I think we know it's possibly part of the problem in certain areas, but I think it's a mistake to think that it's the only issue. Is that fair, John?
Absolutely, and I think, to be honest with you, we are working extremely closely with our primary and community and mental health colleagues, and what is absolutely the case is everybody is under extreme pressure. So it may be difficult to get a GP appointment, but it's only difficult because so many people are after a GP appointment. I think what is absolutely profound, and it's affecting everybody in the system, is the number of people that are presenting with mental health issues as well. That's certainly something we're seeing a dramatic increase at the front door. Primary care are seeing the same. This is a cumulative impact of COVID and people not having been able to access care. But we have previously sometimes been frustrated by some of our partners. I think on the whole, we are standing shoulder to shoulder with our partners, trying to deal with a significant deluge of work because our population needs our help, and it's everybody under pressure rather than just GPs and the failure to get GP appointments.
And I've also seen some stats which very clearly demonstrate that GPs are seeing far more patients virtually in the way that they can at the moment than they ever were seeing before. So, you know, again, as John says, it's really just indicative of the overall pressure across the system, and we have to tackle it together, which is obviously what our work within the ICS is about. Thank you, Mary, for your question. James, can I come to you?
Yes, thank you very much indeed. And notwithstanding anything that you've said, Chair, and totally understand your response to Ian, but I'd just like to develop that a bit further, if I may. Obviously, we're having all these people, as you reported, to the front door. I think the one stat or information you could give us, how many of those are actually becoming inpatients or needing a hospital bed? Because whilst, as we just had the discussion, a lot more people are coming to the front door, it may be that they don't stay at the hospital, they go away. And I think that would be reassuring to us that, you know, the hospital is, as it always does, copes. Thank you.
Thanks, James. John, would you like to respond?
Yeah, I mean, I don't have the figures in front of me now, but I understand the conversion rate, i.e. those people that attend and then are admitted, is running relatively the same, if not increasing. And I think that's indicative of the level of illness that is being presented at the front door. But we are not necessarily seeing, I think this is where, James, your question is probably thinking about, are people coming here as opposed to going to a GP and therefore getting turned around quickly at our front door and then leaving? We're not necessarily seeing that increase in that way. So I think, as I say, the conversion rate between attendance and admissions is increasing slightly, and therefore it's indicative of the fact that we're not seeing a lot of people come to the front door that shouldn't necessarily be here, if you understand that.
And I think, John, the other thing that perhaps governors would want to take and think about was when we have our board meetings, we are discussing different types of services that are currently being planned and thought through, which again we can't report in a public meeting because they haven't been confirmed and they've not been agreed yet or funded. But we are looking at all sorts of different ways of improving the offer, if you like, to ensure that we see as many people as effectively as possible through that time. So I'd encourage you to keep an eye on our, you know, forthcoming board reports, because that will provide perhaps a bit more of the detail that we can't necessarily give you today.
Chair, could I just quickly, very quickly come back on that?
Yeah.
I would think that actually the decision to extend ED and give you more facilities must be one of the very best decisions that has been made in the last 2 years. So thank you.
Well, yes, and I would put that very much in the responsibility for that, and the way in which that has been achieved has been down to our own executive being very canny and careful about the way in which they've put bids in at the right time, and that the hospital has, if you like, set aside resources to be able to ensure that happened. It wasn't a kind of you know, here's a gift type opportunity. It was very much down to the skill of our exec to get that. So thank you for that. And I'm sure John will pass on your thoughts there. Good. So Jane, can I come to you? Would you like to take yourself off mute, Jane?
Yeah, thank you, Chair. Just to say that I've known several people over the last few weeks who've had to use our emergency department, both young and old, and they've said what wonderful treatment and care that they received from the staff at all levels whilst they were in the building, whilst they were in the department. Despite the fact they were really, really busy, and I think one of them actually came on the day when that was probably the busiest. They said that the staff couldn't have been more helpful. They said they were, very kind, caring, patient, and they were going to write to the chief exec because they were so impressed by the care that they've received for the patient, despite them being really, very busy. So I thought it would be pertinent to mention it. Thank you.
Thank you, Jane. That's really nice to hear some positive views expressed by the community. So thank you for feeding those in. Good. So any other questions for John? If not, no, don't think so. So can we then move on the slides to the next section, please, which I think is an update from myself about what I've been doing. So you heard me mention the integrated care system at ICS Partnership Board. As you'll all know, obviously things are moving on in a legal sense, in a statutory sense, and there are changes. I think the bill is at the second reading, but we're still in a bit of a state of flux in terms of knowing exactly what that will mean, but we'll be talking a bit more about that in the private section later on. But nevertheless, the work of the system becomes increasingly important in tackling some of these really, really big and difficult issues that we're all suffering from, and John has alluded to some of those already. So I regularly attend what's called the Interim Norfolk and Waveney ICS Partnership Board, which is rather a mouthful, and there are lots of events that are taking place locally, but also events that I participate in nationally to make sure that we're aware of all of the best practice and the learning that's happening elsewhere. And you'll see the term place there on the slide, and again that really, if you think about place as being the locality really around our hospital, again there are discussions going on as we speak about what the boundaries, if you like, of our places should be, but there is no decision yet. There has been many stakeholder events and engagement, and I know that Jane has taken part in some of those. And again, we'll be looking at some of that paperwork in the private section later on, but there's no decisions yet on exactly how that will work. But again, John and his team at the hospital are very actively engaged in working within the locality around the hospital, so with the GPs, with the councils, to make sure that the offering that we do provide is as joined up as possible. We've also set up, as you know, what's called the Committees in Common meetings with the two other acute trusts, and we've been working together, as you've seen through our board reports, for quite a few years now. So we have effectively been collaborating with our three acute trusts to try to ensure where it makes sense that we deliver things in the same way, and that we reduce inequalities and we improve the quality generally of the services to our patients. We've created our three boards of directors have delegated to this Committees in Common certain decisions which otherwise would have been taken within the individual boards, to try to further that working together and the outcomes from that, to make sure that we do actually move forward with some of the plans that we have. So those meetings take place every month. We have the chair and the chief executive, the strategy directors, and an additional NED from each of the three boards that meet together, and we had one of those meetings indeed earlier this week. they're interesting, they're evolving, it's difficult to really give too much of an indication of the progress we're making, but I do sense we are making progress, and again we'll be giving a little bit more detail as things emerge going forwards. Our three boards have been meeting together. We had a meeting before the pandemic. Obviously, during the worst of the pandemic, it wasn't possible, but we had another tri-board meeting virtually in May. And again, really interesting to meet all of the board members together. And we've got another one that we're planning in October. Those will be really important in ensuring that we develop trust, we develop good relationships with those other two hospitals. We want to see the connectivity, if you like, between those three trusts. We want to develop the understanding that we're all actually dealing with similar problems and that we are more likely to solve them if we work together than by working separately. So with Anna and John potentially, we as CEO, I regularly attend the induction sessions for all staff. They take place roughly every 2 weeks, so they're quite frequent, and we probably have maybe between 20 and 30 staff being inducted at that time. So they're quite important events, I think, for both the chair and the CEO to attend, because it gives us the opportunity to literally meet every new member of staff, which I place great importance on. It's an opportunity for them to meet each other, even though that's virtual at the moment, and it's really a helpful thing for me to be able to see those people and introduce myself. I also take part, as all of the NEDs do, in what are being called quality walkabouts. So those are unannounced visits to ward areas throughout the hospital, obviously socially distanced, masked up and so on, as we will continue to do. But it gives us the opportunity to drop in, if you like, in a way that we're not expected, and we have a look at a whole range of different aspects of the way in which that ward is being managed. And that's led by our Director of Nursing, Paul Morris, or his deputy, Jackie Copping. One of the NEDs always goes, and often another one of the executive as well. So it gives us a really up-to-date view as we work around the hospital of how different wards are coping with some of the stresses and pressures that you've heard about. We're also developing a new programme for our board, because when we were meeting in public, we used to every board meeting, every public day, we would ensure that we'd had a board round around the wards as well. But we are looking at different ways of doing that going forwards, which will potentially be a mixture of virtual and in person, depending on how things progress, obviously, with the pandemic. Other things that I've been involved in, really important things each year, the CEO, I do her performance review and set her objectives for the coming year. So that's really crucial, obviously part of my role. And I did that as well as at the board setting and approving. We all set and approved the trust objectives for 21-22, and obviously I've incorporated those into Anna's review and objective setting for next year. Similarly, I've done all of the non-exec director appraisals now, and those will be reported to yourselves, to the Governor's Nomination and Remuneration Committee, and then to the council in August, because obviously that's part of your role, is to look at how we're performing as non-executive directors. I've also been doing a lot of work over the last few months with the committee chairs, with the NEDs and with Anne Philby, to review how the board committees operate so that we maximise the effectiveness. We make sure that they are actually delivering against their terms of reference, and that they are providing the board with the assurance that they're set up to do that. That is why we have them. And we're now thinking about the board meetings and the committee meetings for the next 12 months. And we hope that we'll be able to introduce some face-to-face meetings over the next 12 months, certainly, but there will be a continuation also of some virtual, because it is an easier way and a more effective way for us to work, particularly at a committee level. You'll also hear a bit more later on about the governor's election process, but obviously I've been involved in that, and we held, I think, 3 different events for prospective governors to give them information about that, and that was facilitated by Jane and Anne, and Jane, as our lead governor, took part in that. So any questions for me on any of that? James.
Yes, thank you very much indeed. Just you mentioned there are 20 new starters every 2 weeks, which is really good to hear that you're being able to recruit that number of people. I assume that we've got a number of people leaving the organisation, otherwise our staff numbers are going up, and we appreciate that we need more staff, I'm sure. But could you just give us an indication of, if we've got 20 starters every 2 weeks, how many are we losing every 2 weeks? Thank you.
No, I can't give you a direct number, James, but the numbers of staff, John, help me out here. We're not growing exponentially, are we, in terms of that? So there is a number of staff who leave, but it kind of balances out as far as I recall. But John, can you help me on that one?
No, you're right. I'm just desperately trying to look through the report right now, but there is obviously there's natural turnover, so we're not growing at 20 a week. Otherwise, we'll be a massive organisation by the end of the year. So we are obviously trying to recruit because we have lost some of our nursing staff that have returned to their home countries due to Brexit, and we're recruiting new staff for that. So there is, James, look, it's an interesting point you make. We're not growing at 20 a week. There is that natural turnover, but we are trying to ensure that we've got the safe staffing levels we do need, obviously.
Yeah, and I guess I'll add to that. I mean, for a start, Nicola will be presenting from the People and Culture meeting in a bit, so you'll get more chance to ask a little bit more about the staffing elements then. But I would say we work to an overall number of staff, as John has said, in terms of our staffing ratio for nursing. So it isn't just we're recruiting exponentially, we're working to the number that we know we need to be able to deliver the things we need to deliver. And we have a very tight budget, as you know, so there isn't money to play with there. But I'm sure Nicola will allude to some of the staffing issues a bit later in her slide, so we can come back to that.
Yeah, thank you very much, Chair. And I certainly wasn't implying that it was running out of control. I'm sure it wasn't. But I think the main point is, and I think the point that is worth making, is obviously if we're having that number of people that you are inducting, James Paget Hospital is attracting staff, which is good, because the reputation of the hospital must go ahead of that recruitment. So thank you.
Yeah. And I perhaps Nicola will allude to some of the work that I know Graham and the team have been doing to actually improve the way of attracting staff. So there's all sorts of things that have been taking place, and they seem to be bearing fruit. So that's really helpful. Any other questions for me at this stage? You can always come back to it later. OK, if you'd like to move on, Bridget, thank you. So this is for David, Chair of Patient Safety and Quality. David.
Thank you, Chair. Yes, I'm Chairman of the Patient Safety and Quality Committee, and there's a lot of detail on this slide. And if I can take it perhaps by going to the very end, because we've had quite a long discussion about the problems with numbers attending ED, and just to say that because of that and concerns, that has been added to the risk register. So just a final sort of a conclusion, if you like, of the discussion about that ED, to say that they were keeping it under a regular review and looking at ways to mitigate the problems through the risk register. To go back to the top, as part of the COVID-19 requirements, we have a specific part of our board assurance framework called the infection control BAF, and as you know, the BAF is one of the ways that the board looks at all the activities of the trust, and this is a very specific report that we review monthly. And recently, this has shown a worrying increase in C. diff. And as you know, this infection can occur if there's overuse or misuse of antibiotics. And part of the ways of mitigating this is to get somebody specifically to look at this, and an antimicrobial pharmacist is being recruited as we speak to look at it. It's fair to say that the numbers are still within the limits set on us. And it's also true to say that many other trusts have a similar problem, but it's something that the committee is keeping a very close eye on. We look at infections also in terms of where they are, and one of the concerns, which I think I've reported before, was that initially there were problems with infections following total knee replacements. And a big review was undertaken, and that appears to be now well in control. But following this, there were some problems with hip replacements, but these were not mainly patients who had hip replacements as a planned procedure, but patients who had fractured hips, fractured neck of femur, which is an emergency procedure, and there were some infections in those cases, and that's something we keep a very close eye on. I've had a deep dive and a look at it. It's just something that we keep a very close eye on, and that's again seems to be okay at present. The way data is presented to the committee, and I think Anna's already commented about, we are always looking to improve the ways we report things and how easy it is and how we can get the appropriate assurance. And that's been changed and evolved and developed, and that's relevant just to all of the reports. And I'll mention bullet point 6. It includes research, where we're having a look at the way, because this committee is now looking at research activities, because most of our research activities are in relation to patient numbers, so that it's clinical research and large studies, and so all of the ways we're looking at these processes are being reviewed, so that we can look at when we need to do deep dives and look at data in more detail as necessary. As part of the reports we get and have had worries, and I think I've mentioned this before, the complaints response times were not as good as we would like, but there's been a lot of activity in that area, and those have improved. There's been a review of our, as part of our regular reviews, and we get an annual report about clinical audits, and we had one at the last meeting, and so we have a review, and plans have been approved for those. I am the NED that's responsible for maternity services. I'll take the lead on maternity services at board, and have regular discussions with Kirsty in maternity and Paul Morris, and we also have a monthly review of activities in maternity services, and part of that is in response to the Ockenden report, and there are a number of activities that we were required to undertake and are continually required to undertake to keep an eye on those issues. And Ockenden is really at the forefront of a lot of the discussion and a lot of the reviews. Again, I have get the assurance, and the committee gets the assurance, that these things are being undertaken, but there are issues, for example, in terms of numbers of staff and numbers of consultants, obstetricians, although I hear that there are one has, I think, recently been appointed, and one is in the process, so things are improving there. I think that just covers and gives a flavour of the things we discuss and review at this committee, and I'm happy to take any questions.
Thank you, David. Any questions for David? Again, those of you that would like to do so, you can always have a read through of the detailed quality report that comes to board, which provides all of the background information in relation to this, and that's available on the website for you to open and look at. One of the things I would just pick up on that David has said, which is really, I think, very exciting, is that the board has recently undertaken, we undertake joint training around all sorts of different areas to try and improve our effectiveness. We recently had attended a session virtually on making data count. And it was incredibly helpful and useful, and I think it will result in some changes to some of the look of that quality report, which will make it a bit more easy to actually look at the areas and assess the areas where we need to do more deep dives. So we're always looking to improve, and I think that's an exciting development that you'll perhaps hear more about going forwards.
No more spuddling. It's the most important.
No more spuddling. Yes, good word. Good. And if there are no questions then for David, I can't see any hands up. Could we move on to the next slide, please? And we now come to to Nicola's turn on people and culture. Thank you.
Thank you, and it's really nice to be back at council. My apologies again for missing last time. If only I could be in 2 places at once with my other work, but it's good to be here. So I'll go through the points, and then I'll take up the point about staffing and the recruitment as well. So in the last meeting, which was in June, of the People and Culture Committee, we had a first draft of the education strategy. So it's a big refresh, if you like, of our education strategy. We're going to get the final version in August, so we were able to give some feedback on that. But I think it's fair to say it was suitably aspirational for the Paget, with significant challenges that we face, but some good aspirations around support to education and training for staff. The Paget recognises the importance of education for the quality of our provision, but it's also about job satisfaction for our staff, and that influences our recruitment and retention as well. So we're looking forward to that final version, and then we can really get going on that. We had an update on the People and Culture strategy, and this also links in with the Operation Reset that John was talking about earlier. So we're going to, in our committee, we're going to sort of focus sometimes on 3 particular areas, but we were able to notice progress, which has previously been quite static, and that's it around recruitment, time to hire, that's improving, and leadership training, which I'm going to come on to in just a minute. And each committee, we're going to have a bit of a deep dive on areas that we feel are important. So we looked at ethnic minorities, and there were no concerns raised there in terms of inequality, so equality was good. We looked at mandatory training. We needed to improve our figures on that, and we were able to report of improvement. And we looked at exit interviews, so we are getting some good feedback, but also areas that we can review, and again that's part of our Operation Reset as well. So the leadership programme that we have, that I'm on the 4th bullet point now. The leadership programme, essential really for quality care and staff engagement, and it's also about supporting the well-being of our staff, so it's absolutely crucial. So there's been investment in leadership, and we're going to use resources for that. We're asking managers to talent spot so that we're going to be inclusive to all. So we know that some people are perhaps reticent about putting themselves forward, don't see their potential, they perhaps lack the confidence. And so by the fact that managers are going to talent spot, we think that will really help the right people to be on the programmes. Thinking also particularly, we know that people from ethnic minority groups don't always put themselves forward. And that kind of leads on to the next point about aspiring to be fully inclusive. And we're going to have external support to put in place for 1 year, which will enhance what we already do in that respect. And on the last point there, the new risk to our risk register on bullying and harassment. So we will do a deep dive. There were concerns from the staff survey on that, so we'll do a deep dive, and we need to explore that further. So no doubt I'll be coming back to the committee. I'm happy to just sort of pick up on the point of staffing. So there has been quite a lot of retirements in the last year of our staff, and we have had initiatives to try and encourage some people to come back and do continue some work with us, to go on to sort of in locums and things like that. but also to support new staff coming through. So our experienced staff that are retiring coming back a little bit to do sort of handover and things. We're awaiting quite a few of overseas checks, so people coming in to the country, but you'll appreciate that that's not been easy in the last 18 months. We've also had quite a lot of promotions, so that means that we've got a nice steady flow, promotions particularly up into sort of some of our higher bands of staff. So the summer there's been, it's also a time, you'll appreciate that a lot of students finish their degree programmes and so are coming into the trust, the band 5 level, so that would be our nursing and all our allied health professions, but also other graduates coming into the NHS, so in accountancy and various areas like that. So the summer's going to be quite a busy time, I think, for recruitment. And we've supported the NHS have a big careers sort of push all of the time, particularly now for A-level students, getting them to think about, or those that are choosing their A-levels. So we're sort of 5 years off, if you like, but encouraging people to think about the NHS. So the NHS does a lot for us. And the Paget has also produced a new resource brochure, what it's like to be at the Paget. And I think that it's a really good brochure. I'd encourage you to have a look at it if you can. Perhaps, Anne, we could make it accessible if you haven't seen it already, because I think that is going to be really encouraging for people to come in to the trust. So we've got a steady sort of stream of leavers and new starters. And the other thing that we've improved is our time to hire. So you'll know that I've reported in the past how long it takes from somebody handing in a notice to get them actually on our doorstep, and that time is reducing a little bit. It's only about sort of 1 to 2 weeks at the moment, but you'll appreciate some people have to hand in notice elsewhere, so that some of it's out of our control. I hope that answers your question. I'm happy to then take any more questions.
Thanks, Nicola. I think just to add that the information for new recruits or for people who might be interested in working with Paget, so the brochure you reflected, I believe is on the website. I had a look, and I think it's there that you can open it up so anybody can have a look at that. But I agree with you, it's so much better than what we've had before, so I'm sure it's had an important role. And before I go to questions as well, I just wondered, Karen, I'm going to put you on the spot. If you just wanted to say a little bit about the Inclusion Network, because it refers down to the bullet point about fully inclusive. And Karen is the NED that's leading on diversity and inclusion. So, Karen, could I bring you in very briefly? Are you there?
Yes, thank you, Chair. So, the Inclusion Network has really started to move along now. There's been some regular meetings and fairly well attended, and also in terms of the Operation Reset, there were a number of sessions for people to attend. So we have an ethnic minority inclusion network, which has the terms of reference set up, and that's being led by Dev, one of the governors. And that's getting some momentum, and also really tackling some of the, getting people to kind of really speak up and say what the issues are from being a person from an ethnic minority working within the trust. And there's another group, which is the LGBTQ+ group, which is being led by Nicola Cottingham, again, getting really good attendance. In fact, there's one of those meetings on Friday that I'll be attending, terms of reference set up, and good engagement from staff across the trust. And some really good for the Pride Month. There were some really great activities that happened in the hospital, which were very well appreciated. And again, there was within the Aubergine Cafe a really good celebration day from people from all different ethnic minorities coming together to celebrate diversity, different foods, different events and music again. So there's some real good momentum happening, and I think it's going to be really important in terms of tackling some of the issues that were raised within the staff survey, and I'll be attending in the future.
Thank you so much, Karen. That's really helpful. It just gives a little flavour of what's happening in the hospital relating to that. So any questions for Nicola or indeed for Karen? Okay, we've got some hands up. So can I come first of all to Ian, please?
Yeah, thanks for that report, really useful. And again, also for answering those earlier questions. Congratulations on point 6 in that talent spotting. I think that's really important in moving forward. But in other areas that I'm working with, there's a lot of focus though on succession planning and formalising reviews and planning with that. Could you give me thoughts about where that sits within your strategy?
Nicola.
Thank you. I mean, I think it's fair to say that that's always part of what we do, and again, part of the leadership that we're doing, the investment in leadership training, that will also be part of that, so that you can start early. We recognise the importance of appraisals as well for that, and so it's why we keep an eye on making sure that everyone has their appraisal. So I think it's part of normal business, it's fair to say, so that we can do that. Yeah.
Great, thanks very much.
Thank you. So Lynn or Jim?
Restaff turnover. Question to Nicola, please. You mentioned very briefly exit interview. Who reviews it? Do they review it before that person leaves or afterwards? Because it's important to know the exact reason why that person is leaving rather than just tick boxes. Is it reviewed before they've left or after they've left?
Thank you. A really good question, and it is something that's been of concern. Our exit interviews weren't really helpful to us, and they weren't always happening. So we have improved on that, but it's fair to say there's still work to do. So the exit interview can be at either point. So it's up to the person whether it is before they go or just after. And the person can choose who does the exit interview. So somebody, for example, chose me to do an exit interview. They were an allied health professional, and they knew of me being a NED. So it varies, and I hope therefore shows that it's kind of very much led by the person themselves and what they think will be most helpful to them. But it could be, say, their manager. It's up to them who they want it to be.
Thank you, Nicola. Could I ask John to come in on that one, just to say, you know, how John is the learning from those interviews, it kind of fed back in. So perhaps from an operational perspective, that would be more appropriate for you to answer that.
Yes, thank you, Chair. Yeah, we do capture the key themes from the exit interviews, and where a key theme is becoming a bit of a trend, we're picking that up, and then we work out how we're going to address it. But I think, to be honest with you, exit interviews, they do cover sort of a whole multitude of areas. I don't think there is a key trend coming out of it, but I think what was just said is really, really important. We allow the exit interview to happen at a time and with a person of the person's choice. So if there was an issue with a particular manager, for example, they obviously wouldn't have to do the exit interview with their manager. And I think that's the important thing. But we do review the output of those exit interviews, and where necessary and appropriate, we will then take further action accordingly.
Thank you, John. That's helpful. Hopefully that answers your question there, Jim. Okay, so if there are no other hands up for this slide, could I move on to the next one, please? Bridget, are you there? Oh, lovely. Strategic projects. I'm delighted that John Hennessy is going to take this slide rather than me this morning. So, John, can I ask you to?
That's great. Our Strategic Projects Committee is something that was set up at the beginning of this calendar year. I think it's a really good way to dig down into some of the really important strategic issues. There's 3 areas that we're looking at currently in the Strategic Projects Committee, and I've got a bullet point on each of those. The first one is electronic patient record. This has been something that's been discussed for the last few years, and it's really beginning to build some momentum. I think that the real challenge on this one is the right challenge. We want a single system across the 3 acute trusts. We want data to be able to move back and forth between the hospitals so it's seamless for the patient. And it just should be able to create efficiencies. In addition, if you buy one system implemented at the same time, it should be more cost effective. It is a big challenge for us. I think the phrase digital desert has been used to describe Norfolk in terms of NHS IT systems. We are one of the less developed areas, and we need to leapfrog and get into a position that we really are using the technology to help us. Important progress has been made on this one. The strategic outline case has been approved by the trust board, all 3 trust boards. I think that we at the committee are able to drill down in a little bit more detail. I think one of our roles in terms of talking to the governors is to give you some assurances, and the Deputy Medical Director, Vivek Chitri, and Ed Taylor, the Director of Finance, are heavily involved with this. So they need to make sure that the case that's being put together for all 3 trusts is robust. And from my perspective, I think they're putting an important input into that process that's going to benefit all of Norfolk. So we've seen that go through the strategic outline case. It's a long game that needs to be played to get approval of the NHS region and the national, because it will be a lot of money. We're talking over £100 million life of such a system. Related to this and complementing this is the digital aspirant business case. It kind of overlaps the electronic patient record, but the important thing is that the same people are doing it and they're recognizing it. The Norfolk health economy has attracted additional funding, and so they're making sure that this money is spent intelligently in a way that will complement when we eventually start putting in the electronic patient record. So that's the first of the projects we look at. The second is the Diagnostic Assessment Center. Again, about 2 years ago, Norfolk was awarded quite sizable capital amounts. I'm not going to quote a figure because I don't remember the exact amounts. John might be able to help me if anyone wants to quiz us on that. But they've attracted the money, and the important thing was it was going to be done in a consolidated way across the 3 acute trusts. This is progressing. The outlined business case, we're expecting that to come to the August Trust Board, and then it will be agreed by all 3 trusts at the Committee in Common September. This is really important. The NHS England has some of the poorest coverage of MRI and this type of diagnostics of anywhere in Europe, and we need to get caught up on this. So this investment is desperately needed, and we're seeing good plans. Again, in terms of reassurance, Jo Segesby really does understand what needs to be done, and she's done a good job of working with the other trusts to push what's needed for James Paget as part of the overall business case. The third area we're looking at, and I'll be brief because we did have a briefing in May to the council on that, is the new hospital program. We're going through this process right now. It's a big project, and Mark Flynn's beginning to have a team around him to really start pushing this. As the bullet point says, we've taken a look at the clinical strategy. This is the first draft of it. I think that the real challenge here is that at the same time James Paget is looking at its clinical strategy, we need to see how it fits together with all of Norfolk, and I think some of the meetings and committees in Common are pushing that, and I know that John is heavily involved with how we're going to pull together these strategies across the health economy and all of the changes that are happening. I think we had some healthcare planning workshops taking place. I think the last thing I'll highlight in terms of assurance to the Board of Governors, we had a seminar session on how NHS business cases need to be pulled together. We needed to understand the Green Book, that's the government's rule book on how to put business cases together, and all the NHS guidance. I think it's really helpful to understand the process so that we understand how an outlined business case to full business case gets done, and the different aspects of that. So we're getting that type of training to make sure that we don't stumble and we address all of the appropriate issues at the beginning. Again, the final thing is the strategic outline case. They're aiming for a December deadline to get that. That will be the first stage in this process. I'm happy to take any questions. I think that I'm going to call a friend if I need to, John Barber, if I need help with any of the details, but does anyone have any questions?
Thank you, John. Very well summarised there. So very important committee, very exciting committee to be part of, because it's actually looking at tangible projects, which is always fun. John, would you like to come in?
Yeah, no, just briefly, it was a really good update from John, but and I will be talking much more in private board about the clinical strategy and how that all interlinks with our new hospitals programme. But just so that governors are aware that we are part of, and I think it was in the region of £70 million, the Diagnostic Assessment Centre funding for the system. But obviously we're going to be building that way before we build the new hospital. So, but just so that we are all quite clear that the position and location of that Diagnostic Assessment Centre will align with our plans for the new hospital, because there would be nothing more embarrassing in terms of public money being deployed to go and build something which in a few years' time with a new hospital would be not in the right place, etc., etc. So although we are looking into the long term about the how we're going to build and the nature of the building of the new hospital, we've got to have an eye on what we're doing right now to make sure that everything we do now aligns with what we're going to do in the future. Thank you.
Thank you, John. And just to reiterate, you'll be going into a bit more detail in the private section, so we won't go into too much detail at this stage, but very, very happy for governors to ask any questions you like on any of those 3 key projects that we're undertaking. So anybody like to raise a hand? Any questions for John or John? No, no questions on that one. OK, thank you. Would we like to move on then, please, Bridget, to the next slide? Thank you. And Paula, would you like to take us through Performance and Finance Committee? Thank you.
Yes, thank you, Chair. Quite a bit of what I did want to bring up has already been discussed, so I'll probably be able to be quite brief. Also, I am reporting on our last meeting, which was actually held in mid-May. We've got another one next week. We have been recently, you may remember, meeting only every 2 months, so there can be quite a long gap in between reports to the board and then what I'm able to report to you as governors. So we did have finance and performance reports presented to our June board meeting as usual, so that the board was able to get assurance about our progress. It was assured in terms of finance, but as you've heard, there are a lot of concerns about performance, including relative to our national targets, of which we're only able to meet 60% at the moment because of the pressure on the hospital. So the board has directed the Finance and Performance Committee to move back to monthly meetings, and in fact we will be doing that for the time being, but I suspect that there will be more pressure on finances as time goes on in the back half of this financial year. So it may be that we have to have a focus on finance and performance at that time. But at the moment, our next meeting, our next in-between meeting, if you like, will focus on the operational side of things. One of the issues that we have talked about is the long waiting list. And on the risk register is obviously the risk of clinical deterioration, clinical risk to those patients who are waiting a long time or waiting at all for their surgery. And that risk is deemed to be much more a patient safety and quality risk. So that's now gone to David's committee, the Patient Safety and Quality Committee, for detailed scrutiny to make sure that the Trust has, and we as directors have assurance on that. As we've discussed earlier, things are improving, but there are still many patients who are waiting a very long time for their surgery. And there are particular, despite our progress, there are particular disciplines which are the ones we know about, where there are still long waiting lists, which include orthopaedics, ophthalmology, and patients who need orthodontic surgery. So that's just briefly in terms of performance. I should just mention my own continued concern, and we talked about patients coming into the hospital, but it's equally important that we keep a very, very close eye on the number of beds that are being taken by patients who are medically fit for discharge. And as John says, we're working closely with the system, but that number continues to be far too high. And this committee will continue to put detailed scrutiny on that to make sure we're doing everything we can with our partners to make the best use of the beds in the hospital. Moving on now to finance. The first half, there's less risk financially with regard to the first half of this financial year because of the financial regime. We're strongly supported so that COVID isn't a barrier to us meeting our financial targets. We are waiting detailed clarification, the financial regime for months 6 to 12, and that is going to not unexpectedly become tougher. The risks and mitigation, both for performance and finance, will be clearly articulated in our transformation plan, a bit of which John's told you about earlier. And if you take anything away from this, I think that the thing that you should take away is that our focus will be on elective recovery, both from and this is, as you probably know, the new Secretary of State's focus, but it's a real challenge for us and for the whole of the NHS. And I think financially it's going to be a real challenge, and we're just having to wrestle with the new elective recovery fund and the risk of whether we're going to be able to make the balance, our books balance relative to the work we're doing and the money we're receiving to do that work. But more of that in future months. So thank you. I'm happy to take any questions, again assisted by John if need be.
Sorry, I was busy talking to a mute microphone. John, is that something you want to add there?
Well, yeah, no, I think that was a really good update, but I think the word used there was wrestle, and I think that's a really important word. It's wrestling the financial savings we know we're going to have to make in the second half of this financial year, and the unwavering focus on elective recovery. Just again to give some confidence, what we're doing, we know we're going to have to make some financial savings, so we're working across the acutes and across the system to do that. We have an ICS strategic planning and transformation group, and we're identifying those projects where we can see about releasing cashable savings in a way which focuses on patient care, but doing it together rather than necessarily looking at individual savings targets within the trust, which we'll have to do anyway. But we're taking that holistic system view as well as a trust approach to it, and our transformation programme will have to ramp up in the second half of this year to address those aforementioned savings we're going to have to make. But I think the word wrestling was a really good word.
Thank you, John. Any questions for Paula on finance or performance? As you heard her say, I think it is important that we're moving back to monthly reviews certainly on the performance side at this point, but it may well be, as Paula says, we'll need to concentrate equally on finance in the latter half of the year. Okay, so no hands up there. So can we move on to the next slide, please, Bridget? And over to Stephen to give us an overview of Audit Committee. Thank you, Stephen.
Thanks a lot. Good morning, all. There's quite a lot going on behind what is a relatively simple slide here, particularly in the first part regarding the financial statements. So I'll try and explain it to you very carefully. The accounts and audit findings were approved by Audit Committee on the 20th and the 27th of May in 2 meetings, and then subsequently approved by Board on the 28th of May. So the commentary regarding the value for money is the important part here, and so it goes something like this. the value for money piece is now not only dealt with in the audit findings, which we've got in the private meeting this afternoon, but in what will be a new annual audit report, which is a public document as opposed to the audit findings, which are private. And in the meeting on the 20th of May, KPMG made a comment that they might not be able to complete the value for money work, which was a more extensive and new process for them. They were pretty relaxed about it, but I have to say that the audit committee weren't, both from a regulatory and a reputational risk, in that we wouldn't then be able to sign off the certificate of audit completion on the 15th of June, which was the concern. Anyway, long story short, we put a lot of pressure on KPMG, which they responded to have all of the work complete and be in readiness to sign the document on the 15th. And indeed, our team within the finance team responded equally well. And we were in a position on the 15th of June to sign the document. Then the saga didn't stop there. When I say we were in a position to sign, KPMG felt that there was enough evidence to sign the document, and as I say, we were ready to go. But actually, KPMG nationally had a huge IT glitch and couldn't send off any of the documentation. So NHSEI decided to actually, despite having had all this pressure, to extend the deadline to the 29th of June. And in the end, we were able to sign off once the IT systems were all up and running on the 17th of June with no issues or concerns. And so it was all right on the night. The subtlety within all of that is that I said that we were ready, and KPMG felt that we were ready or in a place to sign off on the value for money. But it didn't mean that we had completed the new annual audit report, which will actually be received by Audit Committee next week on the 22nd of July. They aren't that document and the value for money document within the audit findings, which is in the private meeting, aren't very dissimilar. So, but you will hear about and have me comment on the annual audit report in future meetings. So at the end of all of that, just to say, because of some of the issues we've had this year, and it hasn't been straightforward in getting over the line, Anna Hills, Ed as the finance director, myself, and the KPMG are going to have a sit down on Monday, the 19th, just to work through everything that happened this year to make sure we're in a better place for next year. So that's the story behind the financial statements. And as I say, it was all right on the night. In terms of 21-22 plans in place, I'm not sure, probably my fault, external audit slipped into there. There is no external audit 21-22 plan until the back end of the financial year, and it's probably a reference to the 2021 audit, which is now all done and dusted as I've been talking. Internal audit plan is in place for 21-22 and will cover key financial systems, IT controls and governance, data security, premises, and also items that were stopped because of COVID or procedures that were stopped because of COVID and haven't been reinstated. So we're having a look at what that means to the trust. And also the local counter fraud service, and the plan for 21-22 is in place. I have no concerns with that, and it's pretty straightforward, he says, touching wood at the moment. Then moving on, we've completed all of the internal audits for 2021, which is in that bottom section. The controlled drugs was a one-off piece of work because of concerns we had that you'll be aware of within the trust. There's 10 recommendations that went with that, and they're essentially and an action plan is in place with all recommendations to be completed by October, but the majority by the end of September. The IT remote working is absolutely under control, with 4 recommendations, just 3 medium risk and 1 low, essentially around guidance around web and cloud-based applications not being documented for people who are working off-site, and some stuff around phishing simulations. Consultant job planning is pretty well done and dusted, so I'm not going to dwell on that. As regards duty of candour, that had 4 recommendations: 1 high risk, 1 medium. No, I lie, actually. We ended up with all mediums on that because it was amended subsequently. But basically around processes not being followed. You'll remember that this was the 2nd report on duty of candour, where, because we were not happy that the first report included sampling of processes, and indeed there were some issues. All of the recommendations are underway and should have been completed by the end of June. And there's also been some work on post-COVID risk assessments, which isn't on the slide. And there were a couple of recommendations there to improve the way that the risk assessments were used, and also particularly around how they were being used around vulnerable groups, which are both complete and in hand. And then just beyond that, just to say that we continue to drill down at each meeting with all of the directors in terms of their risks, and we also look at horizon scanning as an ongoing basis. So that's a canter through all of that, and I'm happy to take any questions.
Thank you, Stephen. Really helpful. Okay, so any questions for Stephen on audit? Anne, you've got a comment?
Yeah, I just wanted to confirm that the annual report and financial statements have now been laid before Parliament. That took place on Monday.
Thank you. Stephen, I'm just going to put you on mute because we're getting a little bit of echo. I'll put you back on if you need to come back in. Any other questions? Any questions for Stephen? No. Okay. Well, thank you very much to all the people that have given their slides this morning. I'm just to a little bit of a summarising really of that element of our meeting. You'll recall as governors that the key, one of your key responsibilities is to hold the NEDs to account for the performance of the Board of Directors. So this is our way of proving and giving you that evidence that we have we're on top of our own individual briefs. So that's why we go to each of the individual NEDs to provide you with that assurance and to take questions. So it is a really important part of the meeting, and I know that we're held as an exemplar nationally because of the way in which we do this. So I think that also gives you some assurance. And so when we're looked at by CQC, obviously part of the well-led assessment does actually look at the way in which we interact with our governors and provide that assurance. And I think we are considered to be, one of the trusts which does this the best across the country, and we're often used as an example for others. So that provides you with another layer of assurance too. So thank you for that part of the meeting. So we're now going to move on to the report on the quality report, and I'm going to ask Anne to take us through that.
Thank you. So this is just a brief report for Council's information. So the requirements each year for the quality report is there's an element which is called the quality account, which is laid down in legislation, and we're required to produce one of those every year. The quality report element is the additional information that we choose to add in to sort of celebrate the work that we've done to enhance the experience of patients. And the board agreed earlier this year that they did want to provide a full quality report. So part of that quality account is stakeholder comments, and the council has a role in preparing a comment. Unfortunately, at the May meeting, we weren't in a position to present much of an update to governors. Normally, you would have a draft of that. Because of changes in timeframes, that wasn't possible. So you'll recall that we emailed out to get some comments if you'd like those taken into account. And what I've presented here is the final input that went into the quality report that's now published on our website and on the NHS website, which we did by the required deadline of the 30th of June. And then the final section there just reflects comments that have been made through council during the year about putting on record their thanks for everything that the board and all staff have done in a very challenging year. So happy to take any questions.
Thank you, Anne. So any questions of Anne for this paper? No? Okay, thank you. It's only to note that then, Anne, isn't it? There's no...
Yeah.
And the next item, I think, is the verbal item, Anne. You're going to give us a little bit of an update on where we are with elections for governors.
Yes, thank you. So the nominations closed last Wednesday at 5 o'clock. We will be going to poll for the staff constituency. So we have 5 candidates for 4 vacancies. Unfortunately, we won't be going to poll for public. We only received 9 nominations for the 10 vacancies that we've had. This is the first time since 2006 that we haven't had sufficient nominations, and I think it was quite noticeable that there was a lack of engagement this year, and we did a lot of communication, so that's certainly something that we want to look at. Certainly Anna and I have discussed it, and we just wonder whether it is sort of the pandemic, lots of other things that people are concerned about, and we've had lots of volunteers support the pandemic, and we wonder whether they're not willing to sign up for a 3-year process to support the governors. So we will be welcoming Ian and Sheena back onto the council. So thank you very much for standing. So we look forward to working with you again. Obviously, over in the coming weeks, I'll be working on the sort of letters to all of you, whether you're staying with us or whether you're finishing. And obviously the induction process that will start in September, but the new council will start from the 1st of September for 3 years. We'll also in the autumn consider what we want to do in terms of next steps, because that will mean running 1 public governor less than we would normally have, and consider whether we want to go to election at a later date. But I don't think we should be doing that this summer, but we'll think about that in the autumn. So happy to take any questions.
Thank you, Anne. Any questions at all for Anne on that? Yes, James.
Yes, thank you very much. Is it possible and allowed to co-opt somebody into that spare space? Because whilst I know that's going against election kind of procedure, would that be an opportunity to find an appropriate candidate? Thank you.
Potentially, but they wouldn't be voting because they haven't been elected in line with our constitution and our election rules.
And so what we'll do, James, is we'll have a think about all the options and discuss those with our council in due course, I think, when we work out where we are. But I think at this stage we're not proposing any change. Jim.
Because of my age being 85 next birthday, I did not put myself up for re-election, mainly because of the 3-year period. I don't know whether I'm still going to be alive in 3 years. Is this mandatory for all hospital trusts to have a 3-year period? Why can't you go down to 2 years or even 1 year? Is it 3 years government regulation for all hospital trusts?
Okay, Anne, come on.
So the term in legislation is you can't serve longer than 3 years. We used to elect every year, but we tended to still do it for 3-year process. So it's partly cost, partly we moved to doing everything every 3 years because it was quite disruptive to the council to have a third of new governors come in every year. So yeah, we've always elected for a 3-year period, really, because it's quite a lot of work to go through an election process, as well as with the cost too, because obviously we're required to have an independent election provider, and that although the cost has come down over the years, that's not a cheap thing to do, but it's absolutely essential to run appropriate elections.
Can I come back?
Of course you can, Jim. Yeah.
It seemed a shame when you think of all the hours and hours I spent listening to all what's going on, all the training, all the filling in of all the paperwork, how many fire extinguishers and how to lift up a box, and it's all wasted after 1 year. It seems to me, from people I speak to, 2 years would have been more than adequate. Anyway, that's my personal view.
Thank you.
If I was younger, I would sign up for 3 years. You know, I've enjoyed every minute of it. It's been great. I've learned a lot about the hospitals. I've got total admiration for the hospital and its staff and all the rest of it. The flags are flying in my garden all the time, supporting the NHS, etc., etc. But it just seemed a waste of all those resources for the last year, that I can't be with you again for another 1 year or 2 years. 3 years, I'll be 88 years of age, and I may not be on this mortal earth anymore. So that was just my personal view.
Well, we hope you're wrong, Jim, because you're a pillar of the community, and you do an awful lot of good for everyone around. So, and we've very much appreciated you being with us, albeit only recently being able to see you, which is lovely. So it's great, and thank you to Lynn for enabling that to happen. So Sheena's got a hand up, and then James.
Me?
Yes, Sheena. Yep, over to you. Okay, Sheena, what you're going to have to do is hit your mute button and then wait for a minute, and then you can speak. That's it.
Can you hear me now?
Yes, we can. There we go.
So I'm assuming then that Lewis, because whatever isn't, so could he not be
No, he
like
is, he is, Sheena.
Oh, is he?
Yes, he is.
Oh, fantastic. Oh, he'll be well chuffed.
We can't give too many details at this point, Sheena.
Okay,
obviously
sorry.
we haven't written to everybody, but you know, yes, effectively, if it's not contested, it means that those who applied get in.
Oh, thank you.
That's
Sorry.
what it means. Yeah. Okay.
So we're really pleased, Sheena, because we'll have a younger governor, which will be great in terms of our representative membership.
Absolutely, and that's what he's been on about. He said, I think there should be younger people, and I've got this idea and that idea, and it's a different perspective, isn't it?
Yeah, absolutely. That will really add to the council.
Thank you.
Look forward to that, Sheena.
Thank you.
Yes, could I just come back on my point about a co-opted governor? And whilst we're looking, considering and thinking, could I suggest that Jim would be an ideal candidate for a co-opted governor for that period of time? I can see I put you on the spot, Chairman, but hey ho.
At this stage, we're not in a position to agree that, James. Sorry, I'm getting all my Jameses and my Jims and my Johns mixed up. We need to really have a reflection and a think about where we are before we move that on. But I take your nomination in good heart, and we'll certainly bear that in mind when we get the opportunity to think it through. But what we need is a proper paper to discuss, you know, what the meanings are, and that can only really happen when we've got our new council appointed and people have accepted the roles and so on and so forth. At this stage, we're still not in there at that point, and the new council, just to remind people, starts in September. So we've got a little bit of time to think through those implications. But thank you for your comments. That's lovely. Okay, so I think that takes us to the end of the formal agenda. Does anyone have any other business for the public meeting that they might wish to bring in? Mary?
Must apologise, I have sent an amended register of interest form in because I've had to amend it.
Okay.
I'm now a stakeholder governor of the NEFT.
Okay, so SNF, which is the Mental Health Trust.
No, it's East Suffolk, the North East Essex.
No, sorry, I'm the wrong one, aren't I? That's right. So you're the Acute Trust in Essex and Suffolk.
I have sent the form in to Sue to amend it.
Lovely. Thank you for letting us know, Mary. That's really helpful. Any other business? No, okay. And we don't have any members from the public here, so we have no external questions. So we just finally, just to confirm that the date of the next meeting will be, which will be the last one of this council, will be the 18th of August. And so we look forward to seeing you all then. Thank you so much all for your attendance this morning. We'll now have a short break before logging on to the next meeting. Anne, is that correct?
Yeah, is it worth us, because I think we were due to start the next one at, oh, can't find my agenda, at 10:55, as we've finished early. Is it worth starting at maybe 1:45? Is 10 minutes enough as a break?
I think that sounds like a fine idea, because I know that for the executive, for John and others, that would be quite helpful. So let's start at 1:45, but you need to log into your next link, not this one. So we'll all leave now and we'll see you all in about 10 minutes or so. Lovely. Thank you all very much indeed. Bye-bye.